Jean Twenge, she used to be a student of Roy Baumeister's, who claims that all that self-esteem training has just, made younger people like you guys more, what do you call that? Narcissistic. Yeah, because the self-esteem becomes disconnected from the actual accomplishment. Because you might go, well, This is In the Loop, but it's not with Christian Bryant, at least for the next few days. I'm Bianca Fascini. Here's what we have for you in this episode. A lot of you might be watching this now on a streaming device, from our website, or maybe later on YouTube. In other words, many of you are relying on solid internet connection to join us here at Newsy. And that's something a lot of us might be taking for granted. Simple access to the internet for everyday tasks. Many Americans can't reliably afford internet access. During this pandemic, internet access has become more crucial than ever. The bipartisan infrastructure bill, which passed earlier this year, dedicated about $65 billion to expand high-speed internet across the country. Part of the bill is specifically aimed at helping low-income households pay for internet. So fixing this digital divide may be a bigger priority going forward, but until that aid arrives, many communities will still be struggling. To try and ease the strain in the meantime, national correspondent Axel Tercios takes us to one of these neighborhoods and introduces us to one nonprofit dedicated to making accessible internet a reality.
He scales buildings, spends hours on New York City rooftops. Yet, he's not a superhero, although some might think these efforts are heroic.
The increased capacity of work from home, learning from home, and etc. during the pandemic. So NYC Mesh hopes to be an alternative so people can have more reliable access in various parts of the city.
Scaling a roof is a typical task for Daniel Heredia. Every step he takes, he does with care, handling equipment with precision to allow another New Yorker to get access to high-speed internet. Heredia is a volunteer for NYC Mesh, a nonprofit organization that provides affordable Wi-Fi access to low-income communities in New York City.
This is an example of one antennas we use in the mesh. This will connect to a local neighborhood hub, which in turn has antennas that connect to our supernodes in New York City.
This new member just got her router installed in her Brooklyn apartment.
Well, I decided to email them because my Spectrum bill had gone up $20 in the past year per month for like the same spotty service.
So far, NYC Mesh has provided internet to more than 4,000 New Yorkers or members. That's what they like to call them. Internet in the city runs from $50 to $110 a month for high-speed internet, a price that many cannot afford.
It's a much more affordable option for internet in New York, and I also like it that it's something that can be offered to people at different income levels.
To fund their services, NYC Mesh charges a flat upfront fee of $240 for equipment, plus a $50 tip for the volunteer. In this case, Heredia.
For me, it's important, especially in these community networks, to try to pass along the knowledge to more people. You know, it's awesome that I can do it and a couple other people can do it, but the importance of being a community network is that we are neighbors and we can help each other.
The installation takes about 2 hours. Members are asked for a $20 monthly donation. Heredia says that most internet providers still use obsolete technology to distribute their services. That caused many people to experience connection issues at home during quarantine.
NYC Mesh serves to basically give an alternative using completely different technologies that are able to more deal with a lot more people working from home than the typical cable providers.
Heredia became a volunteer after getting the services for himself.
To get to the rooftop, sometimes the volunteers even have to climb ladders. And most of the times they're alone. They have to carry heavy equipment up to the rooftops. Daniel Heredia tells me he does as many as 4 installations per week. Daniel, do you ever get scared by going onto rooftops?
Not really. I mean, you know, since I've been doing this since last year, October, you know, I feel like at this point I'm used to the risk and I know how to be safe on the roofs. And, you know, we're just doing this to help the community. So it's important for me to do it.
He says going on top of roofs reminds him of his childhood.
You know, I grew up in Brooklyn in a brownstone similar to this. And, you know, it used to be like for 4th of July or for New Year's, we would go up to the roof and see the fireworks almost all year round, just to see any sort of fireworks. So I'm used to being on the roof, so this is just natural to me. Now you know the configuration is complete.
Yeah. Axel Terzius, Newsy, New York City.
This is In the Loop. I'm Christian Bryant. Many thanks for tuning in, folks. You could be off worrying about holiday travel or relearning how to wrap gifts, which is a skill I only use once a year, if that, but instead, you're here with us. But first, Congress recently approved raising the debt ceiling by $2.5 trillion.
The resolution we will vote on will provide for raising of the debt limit to a level commensurate with funding necessary to get into 2023.
Now, that's a lot of money, but if they didn't raise it, the country wouldn't be able to pay our bills. Things like Social Security benefits would be delayed, the military wouldn't be paid, and food assistance would stop.
It would be disastrous for the American economy, for global financial markets, and for millions of families and workers whose financial security would be jeopardized by delayed payment.
This move prevented the U.S. from defaulting on our debt for the first time ever, but not everyone was crazy about the idea of raising it.
This idea puts all of us in a box, and I don't appreciate it. And I won't forget it.
We have this debt because we spend more money than we take in. Our current national debt is about $30 trillion. The majority of it was approved in previous years. Raising the debt limit doesn't allow for new spending, but allows the Treasury to pay for spending that's already been approved. But how exactly does the debt ceiling work, and why do we have it in the first place? The US and Denmark are the only Western countries with a debt ceiling, but the way it works looks different in both countries. The US debt ceiling was created in 1917 when Congress passed the Second Liberty Bond Act. Before that, each loan or bond were approved as they were taken out. With the ceiling, there was a limit set for how much could be borrowed that required congressional approval to increase the total amount. Since then, the debt ceiling has been raised dozens of times. Once the limit is hit, the Treasury can take extraordinary measures to extend how long it can continue paying its bills. And the government had to do that for a few months this year as they debated if and how to raise it. Across the way, Denmark established theirs a bit later in the 1990s, but their debt ceiling is so high that they rarely get close to it. So it's not a recurring debate like it is here in the US. The closest they ever came to reaching their ceiling was in 2010, but then after that, they doubled it. Some places that don't have debt ceilings have what's called a debt brake. It's a rule that debt has to stay under a certain percentage of a country's GDP. We can look to Poland and Germany as examples. Poland aims to stay under 60% of their GDP, and Germany aims to keep borrowing within a third of their GDP. The U.S. should be good for now until after the midterm elections. We're going to stay on this topic for a bit longer and bring in our congressional correspondent, Nathaniel Reed, who spends a lot of time on Capitol Hill, and he reminded me a bit earlier that he's only been on the show a handful of times. So, Nate, we're bringing you in for all the big stuff. We're glad to have you. Can you explain the politics behind the debt ceiling and why lawmakers frequently go back and forth about raising it?
Well, Christian, that's a great question. And look, it's inter-party conflict. It is a political football that they love tossing back and forth. The debt ceiling is a massive issue. They run into it roughly once a year, if not once every other year or so, which is the current extension. We're seeing now that $2.5 trillion. That should get us through the midterms at least. So I guess the political football has been somewhat punted. Remember, if Republicans were to take control of the House or Senate after the midterms, it would be up to them to raise it. There are really two ways to raise it. You can either just suspend it for a period of time, say like a year and a half, 2 years. That's what President Trump did on the most recent occurrence of getting close to hitting the debt ceiling. Or you can raise it by a specific dollar figure. Now, Republicans in this latest iteration made Democrats raise it by a specific dollar figure because it's a political football, because they're able to say now they have their messaging victory. They can say, look, Democrats want to spend $2.5 trillion the next 2 years. Remember, it's larger than that. It's America's credit card. It's things America has already agreed to pay for, not necessarily Democratic priorities, but also Republican priorities and bipartisan priorities like paying the military, things like that, Social Security. So it's a much more complex issue than either party necessarily makes it out to be. One thing that's clear, though, Mitch McConnell, the Senate Republican leader this time around, said U.S. will not default.
Nate, I really appreciate the football imagery. I think this is really helping some of our viewers to understand what's happening right now. I'm curious to know, what is the likelihood of them getting rid of the debt ceiling altogether? There's a hypothetical for you. What's the likelihood of that?
Well, I'd say it's a little bit larger than a hypothetical, Christian. This is something they've discussed year after year of, can we just get rid of this debt ceiling? It's artificial. It doesn't exist in reality. It's an artificial limit on how much the U.S. can borrow. There's nothing that actually says necessarily in the Constitution you are only able to spend XYZ amount of money. It's just an artificial limit, which is more or less a political football created, earlier in the 1900s. So there is talk every couple of years about getting rid of it. But remember, it all comes down to the political football and to optics. What are the optics if a party says we want to get rid of the ceiling of debt, we want to spend as much as possible and not make that accountable to anyone? Now, if you took a blind vote on this, had everyone put their heads down and say, let's vote on getting rid of the debt ceiling, it would probably have a lot of support. But remember, when they're playing politics here, when parties are trying to make the other party look bad, there's no votes to get rid of the debt ceiling on a broad scale, just because you don't want to be the party that gets rid of something, which theoretically keeps track of how much the U.S. is spending.
Newsy congressional correspondent Nathaniel Reed, somebody who we only see every blue moon.
This is In the Loop, but it's not with Christian Bryant, at least for the next few days. I'm Bianca Ficini. Here's what we have for you in this episode. A lot of you might be watching this now on a streaming device, from our website, or maybe later on YouTube. In other words, many of you are relying on solid internet connection to join us here at Newsy. And that's something a lot of us might be taking for granted. Simple access to the internet for everyday tasks. Many Americans can't reliably afford internet access. During this pandemic, internet access has become more crucial than ever. The bipartisan
Despite the surge, the CDC is making a major pivot in their COVID guidance. It now recommends a shorter isolation period, 5 days, not 10, for Americans who test positive for COVID. If you've just been exposed to COVID, you could skip the quarantine altogether if you have your vaccine and booster. You're just asked to wear a mask for 10 days after exposure. Things change if you're unvaccinated or if you got fully vaccinated more than 6 months ago and don't have a booster. You're asked to quarantine for 5 days on exposure and wear a mask for another 5. Dr. William Schaffner is a CDC advisor and an infectious disease specialist at Vanderbilt University School of Medicine and a friend of the network. Dr. Schaffner, it is great to see you again tonight. Can you walk us through the science that prompted this change and what risks there may be in changing this guidance? Because it seems like a really big pivot, 10 to 5, while we're seeing this spike in Omicron.
Well, James, I'm not Spider-Man. I am COVID-Man. But let's talk about these new changes that the CDC has recommended, because they really are very, very welcome. The scientific key to all this was the study that with Omicron, the period of most transmission were the day or two before you became ill, and then for the day or two, and maybe up to 3 afterwards. After that, your risk of transmitting the infection, your contagiousness goes way down. And that's where those 5 days come in. Gives you a little bit of an extra barrier, and that would make all of us comfortable then in getting off our isolation, continuing to wear our masks, but we could go back to work. And that's something that I think will be welcomed by the healthcare community, the airlines, just about everybody out there.
Can I just quickly follow up on that, though, because we did see some response from particularly the head of like the flight attendants union, the biggest flight attendants union, saying 5 days is a little concerning because it's what she had seen corporate America pushing. Are you completely confident that this is science driven and it's not about businesses trying to get workers back in the workplace faster after they've gotten sick?
I think this is solidly science driven. The CDC and the president's advisors in Washington have been discussing this for some time. As you will remember, the first decision was made to let healthcare workers do that. We who go back and take care of other patients with these illnesses. And I at the time said, well, if it's true for the healthcare workers, let's expand it to everybody else too.
Yeah. So when you look at these new guidelines and you're looking at guidance for an exposure, not if you've tested positive, but just if you know you've been exposed to the virus, now the guidelines are the same if you were vaccinated more than 6 months ago and don't have your booster yet, and if you're completely unvaccinated. Same exact guidance if you've been exposed for those first 5 days. So at this point now, should we consider fully vaccinated to be 3 shots?
Well, certainly from a scientific point of view, 3 shots is by far the best. And most of us consider the vaccine to be a 3-dose series for sure. Whether we want to label it that, which has all kinds of ramifications for changing all kinds of computer programs that are out there, including in my own institution, I think people are saying there's so much change going on. Let's not do that right at the moment. But yes, we are urging everyone to think of this as a 3-dose series.
So are we foregoing something that could be clarifying because it's going to be too much administrative work?
Too much administrative work is an understatement. It would be enormously difficult to change everything that's out there already embedded. And remember, we're trying to get some people vaccinated with their first dose, others with their second, many with their third, children vaccinated. Let's not change too many things at the same time.
Okay. Dr. Fauci now is also floating this idea of maybe we should mandate vaccines if you're going to travel domestically. Do you think that's a good idea?
I think that's a quite reasonable idea because, after all, if we're doing this now internationally and we've got plenty of COVID here, Omicron has long since come here and is spreading widely. It's the dominant strain. We no longer have to protect ourselves from those from abroad. What this is a device to get people who are not vaccinated. That will persuade some of those folks to come on in along with the rest of us and get the vaccine if they'd like to get on that plane. We need that kind of compulsion now, I think. I know it's a bad word, mandates. We need obligations, requirements, even mandates to get people vaccinated finally. So we're all on the same page.
Well, you may not be, as you say, the billion-dollar Spider-Man, Dr. Schaffner, but you are a very valued member of our team around here, and we appreciate you being here once again tonight to kind of walk us through some of this new guidance. It's a big change, kind of confusing for some folks, and we really appreciate your guidance. Thank you, sir.
Happy New Year.
New guidelines from the CDC cutting time in isolation in half from 10 days to 5 days after testing positive for COVID. This comes as an alarming surge in pediatric COVID cases and hospitalization.
million people across the country have permanently lost their sense of smell due to COVID. Adam Wallace spoke with two women struggling with long COVID to learn more about the personal impact of this problem.
Run a marathon or, be running 4 or 5 times a week.
Vicki Jones was a high-intensity fitness instructor in her 50s and former pro pentathlete. But after contracting COVID last summer,
Long COVID has left me unable to exercise. I'm not able to work.
I was dizzy, I had hot flashes, and I was in bed for nearly 6 weeks.
Lydia Pastor is only 17 and spent most of the last 2 years at home, fatigued after a stint with COVID in February of 2020.
It's been 21 months since my initial infection. I take walks every night with my mom, and I was unable to do that when I was sick. I could barely make it to the end of my driveway without being winded.
Both Vicki and Lydia have been diagnosed with long-haul COVID-19, and it's changed their lives forever. While Vicki suffers from brain fog,
Sitting down at the local supermarket in my pajamas. No idea how I got there.
Lydia is slowly rejoining her past normal life.
Now I'm actually able to go to school and participate in a full school day, and it is still a bit difficult. I find that I'm still pretty tired at the end of the day.
A study from Penn State College of Medicine estimates more than 100 million people will suffer from long COVID, meaning anyone showing COVID symptoms after 6 months since first getting the virus. Yet more research is needed for this very personalized illness.
Long-term neurological issues such as that long-term COVID brain, and other people are feeling some long-term breathing difficulties. So it's just a little bit different in everybody.
Both Vicki and Leah, more than 50 years apart in age, with their health changed forever, are hoping they can support others still battling COVID years down the road.
Very grateful that I can coach some people with long COVID because I've become a breathwork coach.
Despite the fact that we all may have different physical symptoms, we're all facing a social stigma associated with chronic illness. And so as I continue to get better, I've tried to deepen my involvement as an advocate for people like myself.
But there is some hope for COVID long haulers. Maya Rodriguez explains how vaccines can make a major difference.
There are COVID survivors, and then there are COVID survivors whose bodies can't seem to kick its symptoms out.
In those cases, we definitely, can help see them and try to do additional treatments and our diagnostic testing.
Not much is known yet about why some patients, so-called COVID long haulers, retain lingering symptoms and others don't.
We were looking for factors that might influence who would experience long COVID symptoms and what the severity might be.
Michael Simon is director of data science at Arcadia, which collects and aggregates healthcare data.
This is part of a larger group, the COVID-19 Patient Recovery Alliance, which is a large group working to identify causes and help develop policies for long COVID.
Researchers there analyzed COVID-19 data for more than 26 million patients, including 1.6 million that got COVID. Then they examined their vaccination statuses, specifically when they got the shot.
Individuals who were vaccinated against COVID, even if they got a diagnosis of COVID, it seems that those who were vaccinated had a reduced likelihood of experiencing long COVID symptoms.
That may not be much of a surprise. People who were vaccinated but still got COVID seem to avoid becoming a long hauler. But for those who had not been vaccinated before getting COVID, researchers made a surprising discovery.
Even if you were vaccinated prior to diagnosis, the sooner after their diagnosis that they were vaccinated, the better protected they were against long COVID symptoms.
In other words, getting a shot from one of the available vaccines after getting COVID reduced the chance of someone developing long-haul symptoms. It's a potential game changer, considering 1 in 3 people infected by COVID will experience long-hauler symptoms, and more than 50 million people in the U.S. have had COVID so far, with more getting infected by the Omicron variant every day.
This kind of study shows that even if we're looking at events that are beyond the point we've already been infected, it seems that there are all still opportunities for your health to be improved through the use of vaccination.
Vaccines that, in America at least, remain available for the taking. I'm Maya Rodriguez.
Earlier, we spoke with epidemiologist Dr. Christopher Labos, and he said the speed at which Omicron is spreading across Canada is surprising, even to medical experts.
rise in Omicron has surpassed, I think, most people's expectations. It's spread very, very quickly. The point to remember, though, and this is an important point that sometimes gets lost, because we've sort of maxed out our testing capacity, it's almost certain that the real number of cases is higher than what's being reported, because a lot of people who would otherwise go and get tested just can't get appointments to get a PCR test. So those numbers of about 10,000 cases is probably an underestimate. There's probably a much larger number of people who are sick with COVID and have either stayed home because they can't get a test or have gotten a rapid test and whose results are not reflected in the official government statistics.
How worrying is it to you right now on that point of testing that it is so hard for people to go access a test? In fact, in some parts of the country, people are being told if you have symptoms, just assume you have COVID.
Well, it's very worrisome because at the very least, what you want to have is you want to have good data so that you know how bad the problem is. The minute you have this problem of non-access to tests, you no longer have a good grasp of how big the problem actually is. You can no longer know for certain how severe the virus is because now the denominator of cases is off. So anytime you add uncertainty in a situation, the harder it becomes to control and the harder it becomes to have to put a appropriate plan in place.
And talking of plans, a lot of people will have had plans with their loved ones. Yesterday on Christmas, we've got New Year's Eve just a few days away as well. How worried are you about how things might look 2 weeks from now?
Fairly worried. I've seen anecdotal reports of people posting photos of large family gatherings, and you sort of wonder, like, oh, is this gonna, are a bunch of people gonna be sick 2 weeks from now? I think this is the real problem. One of the reasons we're probably underestimating the impact of Omicron is the access to testing, but part of it too is that, people tend not to go and get tested during the holidays. They tend to sort of put stuff off. So come the first week of January, I think there's a very real worry that we're going to start to see a surge of cases. And the real worry on that is that surge of cases is then going to lead to a surge of hospitalizations early to mid-January.
Yeah, and even when we hear that maybe Omicron is milder, when you have, these economies of scale, if you have that many people falling sick, of course, we know that will mean more people get to that point of being hospitalized, ending up in intensive care. We were talking during the fourth wave about hospitals and medical staff having to triage patients, decide who would get what care if the resources got stretched. How worried are you that hospitals will get back to that point?
I think it's a very real possibility. I think if you look at what's happening with the airline industry now, where they're canceling a bunch of flights, I think it underscores the problems. Like, yes, you can in theory build more planes, but if you don't have the people to fly them, it doesn't do you any good. And same with hospitals. You can put hospital beds in like unused parts of the hospital or in other places, but if you don't have the personnel to staff them to take care of them, it doesn't matter. And there is a physical limit to our healthcare system, and it's not going to take much to overwhelm it. I mean, our healthcare system gets stretched during most winters because of the flu. When you have a bad COVID season, if you have a lot of COVID cases ending up in hospital, it's not going to be easy to overwhelm. And so we just sort of naturally assume that, when you get sick, there'll be a bed for you at the hospital. You can go there and it won't be an issue. And I think we have to start to at least entertain the possibility that might not actually be true.
And of course, we often think about the healthcare system as, beds and buildings, but it is those healthcare workers as well. We're hearing stories about them falling ill or having to isolate, being taken out of the workforce, which just adds to that strain. I'm wondering if you can tell me how you and your colleagues are feeling right now as you brace for this potentially fifth wave of COVID.
Well, I think everyone's stressed, everyone's tired, everyone's fed up. And here's the thing, it's like, yes, first of all, you have people getting sick because of COVID, and so people are off, and so it's very hard to staff hospitals and clinics. But also people are just getting frustrated and tired, and I think you've already seen the exodus of a certain number.
Welcome back. The district attorney in New Orleans is reviewing dozens of criminal cases linked to a judge caught on camera making racist remarks. Take a listen.
Why are the
When I pull up in the whip, they be saying,
Why are your lights on? They're like, pull up, pull up.
and mom's yelling,
Kid, we have a
look, I oh, that's me.
Okay, so there was a lot of bleeping there, right? In the video, you can hear Judge Michelle Odenay saying the N-word and comparing a black burglary suspect to a roach. She took a leave of absence last week after the video went public, but she says she was on a sedative at the time and doesn't remember the video. And now the New Orleans District Attorney is reviewing all cases she handled during her time as a prosecutor in the 1990s. So for more on this entire situation, let's bring in Louisiana Representative Troy Carter. Good morning, Troy. Thank you so much for joining us because you're also a former New Orleans City Council member. Now, when you hear this and you see this video, what is your reaction about the language that she's using?
Total disgust. The thought that a member of the bench, someone who has the responsibility of making judgments that should be colorblind, to espouse the kind of views and to say the kind of horrible words that she used is quite disturbing. I think it's a travesty.
So when something like this happens, I mean, the only
Members of the jury, have you arrived at a verdict? Okay.
Uh-huh.
It's not always easy to find something all Americans of all ages and political spectrums agree on. There's one thing apparently that we do. We don't trust social media companies with our information. That's the big takeaway from a new Washington Post poll. You see the headline from the paper here, and the subhead reading, quote, pulled between not trusting some tech companies and still wanting to use their products, people look to government regulation. All right, let's bring in Newsy technology correspondent Tyler Atkinson for more insight here. Tyler, it is wonderful to see you, my friend. Not a stretch to say Americans don't trust big tech. I mean, that's been clear for a long time. But I think this shift on internet regulation on these big companies is a little bit of a bigger deal. It's been a sea change where, 10 years ago, we were looking at companies like Facebook and Google as being these stalwarts of American exceptionalism, especially on the capitalism front. And now we're at the point in which, Americans don't trust these companies at all. According to this Washington Post survey in 2012, about 38% of Americans believe that the government needed to do more to regulate how internet companies handle their privacy. And in 2021, that number was all the way up to 64%. We already know that Americans were incredibly concerned with how these tech companies handle their data. I don't think that that's a surprise. That same survey found that nearly 3 in 4 Americans believe that tech companies, that the collection of their user data was an unjustified use of private information. But what's interesting about these findings, I think, is that it represents this sort of growing tension between these companies that we have seen as being essential to America's, business front and the people that use them. And this is also confirming something that a lot of other surveys have found as well. Last year, the Pew Research Center published a survey which found that 3/4 of Americans had little to no confidence in tech companies from preventing the misuse of their platforms to influence the 2020 presidential election. It also found that 64% of American adults say that social media was having a mostly negative effect on the way that, things are going in this country. We're clearly at a place where most Americans look at these tech companies and see them as being problematic for one reason or another at this point. But we haven't really gotten to a point in the U.S. where we've really been able to effectively regulate or kind of hold these companies accountable for those ills. And it's not like these companies are floating on a cloud somewhere with noise-canceling headphones over their ears and have no idea that there's this dissent. Like, they are actively saying,
Yeah, sure, bring it on. And you've seen these ads from Facebook, Meta now, I guess, where they've said, lots changed since the last time internet regulations were changed, and isn't it time for more? You've heard this from Instagram CEO too earlier this month. In fact, we have some sound I think I want to play and just. So, Jibé, I'd like to hear you on the situation at CHSLD, Marguerite Fauchelot in Saint-Hubert. There's about 100 cases over there, a lot of workers infected as well. What's your message to the families of residents, who might be worried, who might think to themselves about what happened at Eran at the beginning of the pandemic? As I mentioned, there are a lot of workers at this CHSLD in Saint-Hubert that are infected. Are you guys aware of the situation? What is the latest? What can you say to the families?
Yeah, we are aware of the situation, and that's the reason at the beginning in my speech that I said that in CHSLD, there are some good news. Even when people are affected, as in this case, most of the the resident, have received a third dose first. So we monitor in each situation, as in this case, what is the severity of those patients, how are they sick really? Because yes, they might have been contaminated, but their status is not in danger. So this is the big difference, because we have been able to administer the third dose in all our CHSLD. But given Omicron, even people that are third dose, where they have an immune system that is probably less effective, that's probably the reason that some are being affected, but they are not really in danger. And we are watching all those situations. We have about, I would say, approximately 800 cases, and 100 are in that one. So this is a very special situation, and we have a team that is following that to make sure that they receive all their services that they should receive. First, we have no choice. We have to make those sort of calls.
Quebec's health minister says the hospital system is under threat. In just days, the province expects 10,000 healthcare workers will be off the job because of COVID. So now they're asking infected doctors, nurses, and hospital employees to still come to work.
We're saying that this is the best alternative compared to not providing cares to the people.
Quebec says the decision of who works will be case by case. A COVID positive employee with mild symptoms could care for patients who also have the virus.
I can imagine a scenario whereby everything is very controlled and you bring back a healthcare worker who tested positive into the hospital and they have adequate protection. But in reality, sometimes in the hospital, things aren't as controlled as we imagine them to be. Things can be hectic.
You might have someone who's a healthcare worker who ends up getting sick, who might have existing conditions, and this might debilitate them and cause more damage to them and to the healthcare system overall.
In the coming days and weeks, Quebec plans to also let other essential employees go to work sick, an option other provinces will likely face soon too.
we will have a shortage of essential workers, not only in hospital, but really everywhere. And we need to find pragmatic solutions that we're just able, to model ourselves through so that life can continue, but it will be a challenge.
Dr. Peter Uni says an important solution as cases climb will be rapid tests, so essential employees can test themselves daily. But that requires there being tests to begin with. They're nearly impossible to track down in some parts of the country.
I think it's real messed up to roll out of the active test, For me, I have to wait in line here, freezing my toes off.
See the queue now. It's going right around the corner. And how much are they giving? 1,000? 2,000? How much are they giving? So everybody then has to come back again over here tomorrow morning if they don't get it.
Mm-hmm.
So, Marina, as provinces are struggling to test and track these cases and make sure there's enough hospital capacity to deal with them, does Quebec have a plan to slow the spread down?
No. The province is really trying to step up vaccine efforts. Right now in Quebec, to get a...
I'd like to hear you on the situation at CHSLD, Marguerite Rochelot in Saint-Hubert. There's about 100 cases over there. A lot of workers infected as well. What's your message to the families of residents, who might be worried, who might think to themselves about what happened at Air?
My question is about the lack of accurate data surrounding daily case numbers. I understand the main indicator you're looking at is hospitalizations, but don't daily case numbers give you an idea of where those hospitalizations are headed?
Yeah, but that's what Dr. Arruda said, and I think it's important to answer that very quickly. Yes, because of the number of cases, is not as precise as before because they are so rapid tests and they are not being published by the patients. But the good news is we have a very good idea of what's happening in terms of hospitalization and with intensive care. If you look at the intensive care, the way they have been growing in the last few weeks is not as intensive, if I may use this pun, to say that, yes, the hospitalization went up quite drastically, but the intensive care have been with minimal impact. That's the good news. And that's the reason when Dr. Arruda said we're following mostly hospitalization and intensive care, we are still in a good number, especially when we need to eliminate the people that are coming in the hospital, not for a COVID reason, but for other reasons. So we are working on that to make sure that we know exactly what is the trend. But right now, we are still in a good situation.
Obviously, with home rapid tests, there are a certain amount of positive cases that aren't being reported. Do we know how many positive cases do we estimate are missing from that total because of rapid tests that were done at home?
No, we don't. No. That's the disadvantage. We'll try to find ways to measure it, but right now the priority was to provide those tests to the population. The way we see the number of tests that have been taken in the pharmacies and the drugstores, we know they're being used a lot. That's good news, but we don't have an approximate numbers of those that are not counted in our daily routine.
Given the high number of cases and how hard it is to track the positive cases, are we in a situation now where we are going to be looking at hospitalizations and deaths as a metric of how serious the pandemic is, as opposed to daily case counts?
That's exactly the thing, because actually, we know this is a very, very transmissible virus. Even if you get two doses, you are protected against going to the hospital and that, but you can transmit the disease. So what is important actually is to make sure that we get the capacity in our healthcare system, so the number of hospitalizations and deaths are going to be a better indicator, and especially also the number of hospitalizations in intensive care and how many people needs ventilation and those things. So I think it's going to be really the fact, and it's why, even if we add more tests, rapid tests is not getting into the count. What we're looking and what is important is hospitalization and hospitalization.
Why? Oh my God. This new measure of allowing asymptomatic healthcare workers to return to work, isn't it too risky just given that maybe there could still be transmission and isn't it just too much of a risk even at this point? Well, I explained earlier, and I will repeat that first, we have no choice. We have to make those sort of calls, but we make them in an environment of risk management. And what does that mean? That means that we're saying that this is the best alternative compared to not providing cares to the people. And because our employees, and thanks to the vaccination, our healthcare employees are up to 98% double dose. So they already have a protection. They already have this protection. And second, we provide them all the environment of personal protection to work. So not only they're double vaccinated, and some of them right now are getting their third dose, but the CNST is finalizing their recommendation on additional equipment that should be provided to them. And we've been saying all along that the minute we have the recommendation, a clear recommendation from CNSST, will provide the additional mask that the recommendation. So this is not an easy decision, but I think it's the best decision in the circumstances.
Do we have an example of what that would actually look like? I mean, are we talking about a nurse who could potentially return to a CHSLD and then be in close proximity to patients? What is that going to look like, and how is that going to actually work?
Well, there is an order of priority that have been discussed for sure, and I'll let Dr. Aguda comment on it. But there will be a guide that have been discussed with the unions in the last few days as to minimizing the risk that we take at the beginning, and depending on how the situation evolves, and we'll take more risk in certain environment. But there is a guide that have been prepared.
Yes,
and I don't know.
And if I can say, first of all, if a healthcare worker is not in good shape at all, we will not ask him to go to work. But there is people who really have some symptoms, very soft ones, who can go work again and they feel okay. We're going to put those infected persons, if they are infected, depending how many days they have been having the symptoms. They could go in certain units where there's already COVID people positive. The patients are going to have a mask. They will use a mask when they're going to be near of the patient. So they're going to apply those things. And don't forget that those two persons are already sick. So it's not, the risk of transmission is not there. That person will not be able to be dining with their colleagues during lunchtime, because it's when they take away their protection and that they can eat, and that was a story of different conditions. Others will be people exposed to cases at home, a kid who will have COVID-19. The nurse can be a contact, but not a case at all. If she's only a contact of a case and has no symptoms, she will be able to go back to work. She's going to be tested at different periods to make sure that if she gets the disease, that we're going to do the work. So there is a lot of conditions, and I would say also it won't be everywhere in the hospital, it won't be everywhere in the CHSLD, but it will be adapted to the reality. Because here, the thing is to balance the care we must give to people and the risk of COVID-19. And we know First of all, if I do have an heart attack soon and have to go to the intensive care, I want to make sure that this doctor is going to treat me because I can die if there is no things. And I would prefer having a cardiologist or an intensivist who was infected doing good job with me than let me die from my heart disease. That's exactly the sense of that, and we won't use that for just as a normal thing. It's an exception thing. It's going to be analyzed, as my minister said, case by case, and we are going from lower risk to high risk in priorities.
Stay home if you are sick. That is the number one message Alberta's UCP government has preached since the beginning of the pandemic. But as Premier Jason Kenney
Hammer, finger. Okay. Come on, you don't think I'm crazy enough to do that. But if I did hit my finger with that hammer, what would happen? It would swell, it would get hot, it would get red, and boy, would it ever hurt. It would be inflamed. Well, inflammation is the body's reaction to an injury. Why the swelling? Because blood rushes to the scene, bringing white blood cells to gobble up the injured cells. There are antibodies that also come in case there's an infection. And of course, it doesn't take all that long for the situation to resolve itself, and the finger heals. Unfortunately, it doesn't always happen so smoothly. Sometimes there is chronic inflammation, and that's a problem. When does that happen? When the body perceives there to be some injury that it can't quite handle, but it keeps trying. For example, when there are deposits in the coronary arteries, that would be a reason for the body to try to get rid of those deposits, but it's not easy to do that. So it keeps attacking those deposits with the white blood cells. And there's constant inflammation, and those white blood cells then release all kinds of chemicals that make the situation worse. The cytokines, the so-called pro-inflammatory substances. That chronic inflammation is linked to all kinds of diseases. We do not want chronic inflammation. Now, sometimes the body just makes a mistake and it starts to attack its own tissues. That's what happens in the case of diabetes or in case of multiple sclerosis or celiac disease, the so-called autoimmune diseases. And sometimes the body makes a mistake with food and it believes that food is somehow the enemy, or at least certain components of food, and tries to attack that, and that also could cause chronic inflammation. How do we know when inflammation is underway? Okay. There are markers. Some of these you have heard of. There's the sedimentation rate. There's a specific protein called the C-reactive protein, or CRP. There's interleukin, there's fibrinogen, and these can be determined by blood tests. So based on such tests, researchers have developed a table of inflammatory foods and which ones cause inflammation and which ones don't cause inflammation. And we're not really surprised to find out which are the good ones and which are the bad ones. It is the stuff that we're being told not to eat all the time anyway, all the fast food. Whereas the green stuff, the fruits and vegetables, the Mediterranean diet, that is what we should be focusing on. So when it comes to inflammation and diet, we are learning quite a bit about that. We know, unfortunately, that the kind of foods that we like, and of course, that's the pizzas and that's the processed meats, those are the ones that will raise those inflammatory markers in the blood. And that, of course, is potentially a problem. Whereas on the other side, we have things like citrus fruits, We have other fruits like the tomato, and my favorite, the berries. These are all anti-inflammatory. And I like to top my berries with some pitted sour cherries. We actually have some scientific evidence that sour cherries are very anti-inflammatory. And of course, I don't want to overplay that. They're not drugs. But there are a lot of people who suffer from arthritis who say that when they increase the sour cherry intake of their diet, they feel better. Is it the placebo effect? Is it real? I don't really know, but it does taste good. So I like to start my day with some blueberries, topped off with some sour cherries. Whether they're really anti-inflammatory or not, you know what? They do taste good. Just one word of warning here. When you buy the sour cherries, make sure you buy the pitted ones. I learned about that the hard way. We're getting into our time machine today, and we'll go back to 1518, Strasbourg. Today it's in France, then it was part of the Holy Roman Empire. And all of a sudden, a lady, Frau Trafau, went out into the street and started to dance in an uncontrolled fashion. And within minutes, she was joined by others. And there was this frantic dancing, and no one knew exactly what was going on. They were dancing, some of them for days, collapsing eventually. There are stories that some of them even died. There were other such events in the Middle Ages as well. What do we say about them? These are well documented. And historians think that these were examples of psychogenic illness. That is, it was all stimulated by the mind. Why? Maybe because life was so miserable back then that people needed some kind of an outlet. Well, today, we have some parallel situations. There was a case in the US where a teacher came into a classroom in a high school and she thought that she smelled something and started to feel nauseous. And she expressed this to the students, and pretty soon, some of the students were also feeling nauseous. Principal was called. They decided to evacuate the school. When the notice went out, students in other classrooms started to complain about nausea and not feeling well. But 100 of them went to hospital. Nothing was found. No physical illness. And the school was thoroughly investigated. No toxins of any kind, no gas of any kind released. Again, an example of psychogenic illness. Very interesting. Today, there are a lot of people who are worried about exposure to electromagnetic radiation coming from things like cell phones, from Wi-Fi, from electric currents running through the house. They say that it causes depression, it causes palpitations, it causes sweating. It just causes them to feel unwell. The question is this psychogenic, or is there something real to it? Well, how do you test for something like this? If there is a subject who is claiming that they have this kind of a sensitivity, you can test it. How? Well, you take them, you put them in an isolation booth, and then you expose them to the electromagnetic radiation that they say they are sensitive to without them knowing when the equipment is turned on or not, and ask them whether or not they are feeling anything. Well, studies like that have been done many times. And today we have review articles, such as this one, which documents 46 such studies, blinded studies where the subject did not know when the equipment was on or not, and they were not able to determine whether or not they were being exposed to electromagnetic radiation, although some of the time they did have symptoms. And this is the so-called nocebo effect. When someone thinks that they are exposed to some harmful situation, very often they can have symptoms. To drive this point home, there's the case of a young man who showed up in an emergency room, and he had palpitations, his heartbeat was high, his blood pressure actually was low, and the doctors questioned him what happened. And he said he had a fight with his girlfriend, and he had swallowed a whole bottle of tablets, and now he was scared that he had poisoned himself. Well, eventually, it turned out that he had been part of a study. And in this study, he had been given some pills. It was a study about antidepressants. And he had taken the whole bottle of pills, wanting to do away with himself. Well, as you can imagine, he survived because it turned out that in this study he had been in the placebo arm. So what he had swallowed were sugar pills. And of course, those could not have caused the symptoms except in his mind. The nocebo effect. Not bad. Nocebo effect at play. Well, don't worry about me because I know what these are. These are homeopathic pills, which mean that they contain absolutely nothing. So I think I'm going to survive this little venture. But I'll leave you with a line from John Milton, the famous British poet, who said, "The mind can make a heaven of hell and a hell of heaven." And if you think about that, that is really true. Tasty homeopathic pills. Today we're going bananas. No, we're not going crazy. Although where that expression actually comes from is somewhat of a mystery. Some suggest that it dates back to the 1960s. And hippies who used to take banana peels and put them in a pipe and smoke it. Why? Because scientific analysis had shown that the peel of the banana contains some interesting compounds like dopamine and serotonin. And they can kind of make you feel happy. Well, I wouldn't put too much weight on that because even though there may be dopamine in there, it doesn't really cross the blood-brain barrier. So we're not going to go crazy about bananas, but we will talk about them because they are interesting. They are the most popular fruit in North America, more popular than apples. Well, actually, we shouldn't say fruit because banana, believe it or not, is actually a berry. And we're familiar with the color of bananas, and some are yellow, that's the way we like them, and some are green. Well, you know, if bananas are picked when they're yellow, they virtually never make it to the marketplace. They will go ripe, overripe, and spoil. So the bananas are picked green and are shipped refrigerated. Now, at their final destination, they are ripened. How? By exposing to a gas called ethylene. Now, that's a natural gas that bananas produce themselves when they ripen. But when they put in a container and they are gassed with ethylene, they will ripen more quickly. Well, what does ripening actually do? It changes some of the starch that is present in the banana, and banana is almost all carbohydrate, most of starch. It changes it to sugar. And the sugars are sucrose and fructose. And there's a lot of sugar in a banana. A fully ripe banana, believe it or not, contains more sugar than a chocolate bar. But it's not so bad because we get a lot of fiber with it. We get minerals and vitamins. And we don't look at sugar that is in food the same way as added sugar. Now, there's another very interesting difference between the yellow and the green bananas. And that is something we refer to as resistant starch. Now, starch is a large molecule made up of glucose units joined together, but there are two kinds of starch. There's amylose, made of straight chain glucose molecules, and amylopectin, which are branched. And they have a different effect on our biochemistry. It turns out that some starch is more resistant to digestion. And this is the kind of starch that is more beneficial for us. This is the starch that doesn't get broken down in the stomach and in the small intestine and be absorbed as glucose in the bloodstream. It goes through to the colon. And there actually it has some benefits because bacteria in the colon like this resistant starch, and they generate from it some so-called short-chain fatty acids, which are very good for the colon. And it also means that there are fewer calories involved in this process because less of the glucose is absorbed. So green bananas are better for us in that sense. They contain more resistant starch, therefore there will be less of a glucose spike in the bloodstream, and it's also better for our colon. And if you have any problems with diarrhea, well, green bananas are better for that as well. There's only one problem with the green banana. It's somewhat harder to peel. And you know what? It isn't quite as tasty as the yellow banana because it contains less sugar. But it contains more resistant starch, which is better for our colon. So, not bad. You know, maybe monkeys are so happy because they eat a lot of bananas, and maybe there's something to the dopamine story. Who knows? The toothbrush. Never go anywhere without it. And indeed, you know, surveys in North America have shown that people voted for the toothbrush as the item that they could not live without. They could live without computers. So they could live without cars. They could live without cell phones, without microwave ovens, but not without the toothbrush. That's pretty interesting. And of course, there's a lot of science behind that because we know that if you don't clean your teeth properly, bacterial growth can be a real problem, not only in terms of tooth decay, but also bacteria getting into the bloodstream. That's been linked to heart disease. One of the most recent studies linked it to erectile dysfunction. So we certainly don't want to be dealing with that. Well, toothbrushes have a long history. Ancient Chinese were making toothbrushes. They would take a piece of bamboo and insert little hairs into it. Where would they get them? Well, that's the reason I have my naked little piggy here, because he lost the bristles from the back of his neck to the original toothbrush. Well, of course, today toothbrushes are no longer made from pig bristles. Today toothbrushes are made from plastic, and the bristles here are made of nylon. Nylon was invented in the 1930s, and it was a huge breakthrough in terms of novel materials. Indeed, the first item ever made of nylon was the toothbrush. People think that it was nylon stockings, but the toothbrush preceded the nylon stockings. Believe it or not, though, there's some controversy about toothbrushes. I had a lady who called me up. She wanted to know where she could find a natural toothbrush. We're getting into our time machine today, and we'll go back to 50.
The message is don't gather and don't go to parties, but at the same time, in theory, the restrictions that were announced yesterday by Quebec allows for that to happen if you want to. So do they not go far enough, in your opinion, what was announced yesterday?
I think at the same time, we're saying to people to be more aware. How do you say it in English? And I will say it in other words. I think maybe it is allowed to go and have 10% or 6% after, but the message is we're having an intense community transmission in Montreal. It's exponential. It's touching young adults. I think we all know and we all see that it is not because it's restricted or you can do it or you cannot do it. I think we're all responsible and we all have to reduce the number of gatherings and the number of people with whom we're gatherings. And if we're doing so, we have to put the measures in place. It's a perception of risk also, but I think everyone has someone in his entourage that is affected of it right now. So we all have to be really vigilant to protect the vulnerable.
Can you open this?
Of the virus. The fast-spreading mutant version of the virus has already cast a pall over Christmas and year-end festivities, forcing people to scale back or call off